Welcome, everybody. Hi, my name is Linda Larson, and I'm a breast imager for the Department of Radiology at the Keck Medicine of USC, University of Southern California in Los Angeles. And I'm very happy to be here today, the moderator of this panel and part of the social media committee for the SBI, which puts on the summer series. Today, I'm going to moderate our session on dense breasts. And before we begin, I'd like the panelists to introduce themselves.
All right, I will get started. I am Rachel Pricer. I'm a breast imager in the Midwest. I am currently a medical director of breast imaging services for Mercy One Northeast Iowa. And I'm happy to be here.
I'm Mitva Patel. I'm an associate professor of breast imaging at OSU, Ohio State University, and I'm also the breast imaging fellowship director.
Hi, I'm Robin Roth. I'm a breast attending at Cooper University Hospital and the fellowship director as well, and I run the social media account, The Booby Docs.
Hi, I'm Mary Yamashita. I'm a clinical associate professor of radiology and surgery, specializing in breast imaging at USC Keck School of Medicine.
Good. So we're going to get started. As most of you know, the dense breast notification law began with Nancy Capello. She's a teacher, a special education teacher and administrator, and in 2003, her doctor felt a lump, and a few weeks earlier, she had a negative mammogram. Then she had another mammogram that was negative, and then ultrasound showed her cancer. So she asked her doctor, what happened with the mammogram, and he explained that she has dense breasts, and mammography can often hide, dense tissue can hide cancer in dense breasts. She'd never heard of this before, and so she began her crusade for women with dense breasts must be informed about the limits of mammography from their doctors. And Mary and I had the fortune of meeting Nancy Capello at RSNA several years ago, and she was invited by Delphinus, the automated whole breast screening ultrasound company, to speak about her journey and her dense breasts and how important it was to do something in addition to mammography. So today, because of her, 38 states require some level of density notification, but not all states require the same level of notification for the patients. And there's no standard from state to state on what patients are told. So my first question to you is, what does your state law require you to tell patients in their letter? Do you tell them that they have dense breasts specifically themselves, heterogeneously dense or extremely dense? Do you tell them that dense breasts can hide cancer? Do you tell them that it's associated with an increased risk of cancer? And do you provide other screening modalities for them to do in that letter? Who wants to?
I'll go first. So in California, the density notification law was passed in 2013, and they're very specific about what to include in the letter. We can't deviate from it. It has 2 paragraphs, and basically it tells the patient that she has dense breast tissue and that dense breast tissue is common, it's not abnormal, but it can make the mammogram harder to detect cancer, and that it may be associated with increased risk of breast cancer. And then it also says the information is given to you so that you can have a conversation with your doctor about what other screening studies need to be done. So it's very specific, but it doesn't give recommendation as to what needs to be done. All it says is you should talk to your doctor.
Mm-hmm.
So I'm in New Jersey, and a big difference is that it's not individualized. It says that you may have dense breast tissue. That's a state law. And that's what's interesting, is that it kind of really leaves it up to the patient to take that extra step to read their report or have their doctor read the report and then decide if it's, right for them. So I wish it was, I think it's confusing because it say you might, you may, but that's not really helpful at all. So I think that's like one of the things that I talk about a lot in the Booby Docs, and why it's important to educate people about why this is important, that mammography alone can miss up to 50% of cancers, especially in dense breast tissue. And that if you are high risk or you want that early detection, then, you know, a supplemental ultrasound or MRI or contrast mammography might be right for you. And that's what I try to spread the word on.
So Ohio was the 20th state to pass a density notification law. It was in 2014, so after California. And we have been, for the past, almost 10 years, we've been sort of just telling patients that they have dense breast tissue. And we were not telling them that it could hide cancer, that it could increase their risk. But we were just saying you have dense breast tissue and to talk to your doctor. But starting next month, at the end of next month, there was another bill that was passed, and we are going to change the wording of our reports. And so now we're going to be able to tell patients, all patients that have dense breast tissue, they'll be notified that they have dense breasts, it can hide cancer, increase their risk, advise them to talk to their doctor, but then it also says that supplemental studies such as screening ultrasound, MR, or contrast enhanced mammography may help. And that bill was passed, I think it's HB, I have to say 371. And it was that wording came together because now Ohio is also requiring insurance companies to cover supplemental screening. So that was sort of a package deal. And I'm really, really happy. I think it'll be a great thing for our patients that we're finally telling them not only do they have dense breast tissue, but we're helping get them coverage for that supplemental screening.
Yeah, that's really great.
Yeah. So in Iowa, we've only had a dense breast law for about 5 years, but it's pretty decent in what it requires us to include. So we have to inform them of their density, and then we do have to talk about masking and increased risk if they have dense breast tissue, and encourage them to talk to their doctors. We don't have to specify what supplemental screening they should have or if they should have supplemental screening. And we do not have an insurance mandate. And that is a huge thing for our patients. When our initial breast density law came about, it really was the product of a lot of hard work from people, just women in Iowa who came together in an organization called Iowa Army of Pink. And they were the ones who made it happen. And I've talked to some of the leaders and the board members of that group, and they specifically did not try to go for that insurance mandate at their first shot for the bill because they were already getting a lot of pushback actually from physicians who didn't want breast density legislation. They thought it was going to be cumbersome for them. It was going to create a lot of questions for them. A lot of radiologists even were against it because it was going to make them have to completely redo all of their BI-RADS letters and all of the mapping. And so they did not want to have insurance companies and doctors both against it. That's why they kind of separated that. But the last 5 years, it's been really tough as a breast imager to start to have these conversations with patients. You have dense breast tissue. You might be, that increases your risk. It makes your mammogram harder to read. There are options to you, but your insurance company is not going to pay for any of them. And it's a big out-of-pocket expense that most patients can't afford. So it's really put patients and breast imagers and other healthcare providers who take care of women in a really tough spot because we're telling them there are these things that you might need, but we can't give them to you because you can't afford them.
Now, do you provide a link for more information in your letter?
We do, but that's not, the link is not necessarily required. That's just a way that we have kind of worked around putting in a lot more extra information and getting our patients some more, access to information.
I think we're going to start doing that. I think that's a really good idea. I think
that's an excellent idea. Yeah, we don't do that right now, but I think that's a really good idea.
Yeah.
And, I feel bad with these letters saying that talk to your provider with more information, because a lot of times the providers aren't even that familiar with breast density notification laws. So I think it's just a flawed system. It's really the radiologist that needs to have the conversation. And I think that's where social media, especially as a breast imager, is really important.
That's a nice segue to my second question is the patient knowledge about breast density. Like, do your patients know what breast density is? And do you discuss it directly with them? And if so, when? Or are you just informing them through the letter? And how does the topic come up? Do you bring it up? Do they bring it up? And is it at screening, diagnosis? I mean, do you think your patients know what breast density is?
I think they're starting to hear about it. Like, they're hearing about dense breast tissue. Do I have it? Is it a problem? What do I do about it? Like, whenever I can, I try to have the conversation. Like, if I call them back for something, I guess the only time to really have a conversation is when they're there for a diagnostic, at least at our practice. And I say, everything looks good. Just so you know, in the future, you have dense breast tissue that places you at increased risk and obscures, cancer. So you'd be a great candidate to have this supplemental screening like ultrasound or MRI. We actually have a dense breast clinic that I often will refer them to, which is where they meet with like a surgical nurse practitioner, and then just kind of does a good physical exam, decides if they need an ultrasound or MRI, or maybe a contrast is we do a lot of contrast there. I think contrast is underutilized test for these women that are intermediate risk and dense tissue. And I would love to explore that more for like screening these intermediate dense people. Yeah.
I think patients, I agree with you, Robin. I think patients know a lot more, probably because of these density notification laws. I remember in the beginning in 2014 having these conversations. And now a lot of times you walk in and you're talking to the patient, while you're scanning or doing or talking to them about their diagnostic mammo results. And they are telling you, yeah, I already know. I know I have dense breast tissue. So I love that. I think that really patients really, the amount of knowledge and education has really increased. And whether part of it, yes, is definitely social media, radiologists getting out there and talking to them. So the only time I think I get a chance to talk to them is really mainly during diagnostic too. We don't really tell our patients their screening results, or the radiologist doesn't. And during the biopsy, when I do get to talk to the patient, I'm really trying to focus on making them comfortable. And so I don't want any more anxiety during the biopsy. I think they're anxious enough. So sometimes I just try to make some casual conversation to distract them if they don't want to talk about that. So
I just want to point out that a lot of the breast density talk on social media is led by patients whose cancer was missed, especially young women, and they're very vocal about it, because all it takes is I had a normal mammogram a few months ago, like Nancy's story, but happens to someone young and motivated about it and on social media, and that's how you kind of get the word out.
Yeah. I mean, it's hard. They did the right thing, right? They got screened and they came in, and yet it was missed. I'm sorry. Go ahead.
No, I was just going to say, even though we've been sending out these letters since 2013, I'm surprised at how many women don't really understand breast density. They will just touch their breasts and they'll say, oh yeah, I have dense breasts. Yeah. It's not about having dense breasts and the way it appears on mammogram. So I do like to educate women, and just like what you said, I talk to them during diagnostic workup. So at the end, I'm always talking to patients. And so I think that's a really good time to bring up breast density and educate them, and let them know that they could have supplemental ultrasound. We just started, not too long ago, started offering whole breast handheld ultrasound. We don't have an automated system yet, so it's not something that we're marketing. We're just doing it when patients ask. But at one of our private facilities, we are in the process of getting SOFI, whole breast ultrasound system. So I think once we get that, we'll be able to get more women to have whole breast ultrasound. But I feel like women that do know about breast density are the ones that had family members or someone who had breast cancer that was sort of missed on mammogram and or not seen on mammogram, but on ultrasound.
I think you make a really good point. I think I have to remember that to remind patients that it's really not just the palpable thing; it's really the imaging findings. So that's a really great point.
Do you think they read the letters that say they have dense breast, or do you think they see it on social media about dense breast, or do you think they know from a friend? I have no idea where they're getting most of their information. I don't know. We did a quick
Yeah, like word of mouth,
Yeah.
I think the efforts on social media and
Now,
I
do
don't
you
know.
provide written materials for the topic in your breast center?
We have pamphlets, but I don't know that anyone ever takes them. They sit in our waiting room, and I truly I don't think anybody has picked one up and taken them with. We don't proactively hand them out. Maybe we should. I mean, maybe we should, for every diagnostic that we see, hand them the DINS breast packet. I do think I think that baseline knowledge about breast density in our community has definitely increased in the last couple of years, but I think there is still a lot of confusion about what it means, because they don't see radiologists very often, if ever, if they're having normal mammograms, but they go in and they see their OB-GYN every single year, and that verbiage that they get clinically on the breast exam, they might say, oh yeah, this is a dense area, and so I think there's a lot of confusion there, but it might not all be our patient's fault. I think there's some confusion there too from our clinical partners, and so I think reaching out to them as well. And I mean, they are really truly our partners in this, and they have to have those conversations just like we do.
So a viewer made a comment that they use the snowball in a snowstorm, and I think that is just a really great visual, and that's really what it feels like sometimes when you see a cancer in an extremely dense breast tissue. So, yeah, that's a great analogy.
And I think you touched upon this, but how do you relay the information about breast density and the supplemental screening to the referring physicians, to the OBGYNs, to the doctors recommending the medicine doctors? Like, how do you get the information out there? Is it different in an academic setting versus a private practice?
I think it's anytime you can, right? Like grand rounds, speaking events, one-on-one, and anytime you really get any interaction with a physician, you try to get that in, if you think that would be beneficial for that patient that you're talking about, or in general, if they have any questions. So I don't think that we could do enough to explain it to them. And it's so confusing. It's even confusing for some radiology centers to decide what supplemental study we're going to offer. I think we struggled with that so much. So should this patient get screening ultrasound? Should they get an MR? Should we be offering, abbreviated MR? I think it can be really confusing. So any opportunity we have, we try to do it, but I think that there's still more that needs to be done in terms of educating clinicians.
I think some of it too is like the culture of your practice. I've only ever been in private practice outside of training, and my last private practice, we were told, do not put in your report if there's dense breast tissue. Recommend whatever supplemental screening you're going to recommend, because our referring providers who we were servicing didn't really want to hear it. And now in another place, they are like, you put it in for every single one. Like, that's our departmental policy. Here is the auto text that does that for us. Even the people who are, maybe a little bit older and don't necessarily want that. So I think a part of it is the culture of your practice.
Yeah, I think educating PCPs is so important. When we started sending out these letters, we would actually get calls from the referring providers really upset that their patients were getting these letters, and the patients were calling them because the letter says to call their PCP. So that's what they're doing, and they didn't know how to answer them. And I had to say, this is the law. It just passed, and we have to do this. And back in 2013, I mean, to be honest, I don't know if I was convinced that whole breast ultrasound was the right thing for women with dense breasts. I am now, but back then I wasn't. So it was more like, okay, well, we provide 3D tomo, and I think that's, at least we're doing something more than just 2D mammogram. And so since then, I've been basically educating the referring providers. I have a CME coming up, so I'll be talking about breast density, and I think it's really important for us to educate them.
Yeah. There's actually a lot of great organizations called like My Density Matters, like Nancy Capello's thing, like a lot of organizations that are really trying to educate. So I like applaud that. And I'm wondering, like, when you're interpreting a mammogram, knowing that like dense breast tissue has this like stigma, like, do you think twice about when you give someone dense breast tissue, or do you kind of upgrade them because you want them to get the whole like ultrasound, or what's your thoughts on that?
That's a great question.
I like it a little bit more. Like, it's not so like, especially if we've been calling them scattered, and I'm like, they're kind of dense though, and I don't, it's hard. Yeah.
I kind of do take into consideration other patient factors. Like if their tyrosine is kind of borderline, and there are some factors in there that I think their tyrosine is not really accurately portraying exactly how at risk they are. I'll lean one way towards dense rather than scattered. Or if it's a younger patient and I'm kind of on the fence between them, I will probably lean more towards dense than scattered, because I think that patient could probably benefit more from supplemental screening. But yeah, it can be tough.
Yeah.
Do you make specific recommendations based on dense breast alone, or do you factor in the risk, if she's high risk or not?
We have a clause we put in every report that says breast dense tissue can obscure, masses, and like talk to your doctor about risk factors and risk and benefits, because, it really should be a discussion. It probably won't, who knows if it will be, but, taking into consideration risk factors, someone has to consider that. Maybe if it's in the patient that's like, you know what, I want this. Like I have dense tissue and I have a family history and I want this. I'm proactive.
Yeah, I try to be really proactive in identifying those high-risk people and just getting them straight into a high-risk screening breast MRI. I think it gets a little bit squidgier when the TC score is kind of in that intermediate range and you have dense breasts. And then it becomes a judgment call, a practice call. I usually, we have the same thing, like a little can statement talking about the breast density. It goes into every report for dense breast people. But I kind of amended the can statement when I started. It was a pretty strong statement about considering abbreviated breast MRI. And in our state, that is not covered by insurance companies. So that's, an almost $600 out-of-pocket expense that not everyone can afford. And especially some of the older patients too, do they really need it? And so I kind of tone down the language, but I do mention it in there for those people, so they at least have the information. If they want to ask their doctor about it, it's in writing in their report that they have access to through their portal.
We've seen an increased number. I don't know about you guys about supplemental screening at your institutions. Have you seen an increased number, especially in patients asking for it?
Yes.
Yeah.
They are asking for it, and that's why we really wanted to wait until we got the automated breast ultrasound system. But because women were asking for it, PCPs were asking, so we have a dedicated breast ultrasound tech she's the only one that does the whole breast ultrasound. So
we've had
by the women.
Yeah, we've had automated breast ultrasound for a couple of years now. And the way it works is because Ohio, definitely in the past, it wasn't covered by insurance, and it can be really expensive. And so what we would do is the patient would get their screening mammogram, and if they were dense, they would get the dense letter, but we'd also have a separate sheet that explained what automated whole breast ultrasound was, and to let them know there could be an additional cost, and just to check with their insurance, and then they could schedule it if they wanted to. And we have had increased numbers of patients coming in. And then subsequent years, they can pair their screening ultrasound with their screening mammogram. But our numbers have definitely gone up.
So do you read the mammogram and the ultrasound at the same time after they leave, or do you give them the results?
Yes. if it's done together, right? So that for that first mammogram, they don't know that they have dense breast tissue, and they're not offered that. They don't know anything about it. So that first one, but subsequent years, we're seeing that they're together, and we pair them together on our screening list. So the same radiologist will look at that. And so it's sort of nice. You can read the TOMO and then read the ABUS together. And then there's not that confusion of one having a 0 and the other. I mean, you do still, if you only see it on one view, you'd only put a 0 on, the ABUS or the screen.
Does it take a long time to read?
Yes. Can I say yes again? So we're lucky right now because no, we're not lucky. When we started it, our volumes were low because it was an out-of-pocket expense sometimes for some patients, or it wasn't covered. But the problem with that is that that forms like sort of two tiers. We're offering a service to some patients based on whether they can afford it, and others that might need it are not getting it. So I am really glad that hopefully more patients will be able to get it, but I don't know what that's going to do to our workflow. I think handheld ultrasound makes a lot of sense in terms of reading, but we wanted to be able to read it like offline, like a screen, and our technologists were not. Our ultrasound techs didn't feel completely comfortable years ago doing whole breast ultrasound themselves and just saving images. And also initially we were told that maybe potentially our mammo techs could do our automated whole breast ultrasound. In some places they do, and we had more mammo techs than ultrasound techs. But how it's worked is that our ultrasound techs do our automated our automated machine. So I think every place is different. You just have to sort of figure out what works for your practice and what works for your state. But that's how we're handling it right now.
Have you seen like a very high increase in number of BI-RADS 3s or biopsies, like from the automated? Yeah.
No, we really thought that we would. I don't know that it's because we paired it with TOMO. So I know those studies before, or maybe 2D or just ABUS. And in the beginning, we were, you watch your numbers and you get a little scared. You're like, you think that it's going to match the studies out there, right? And it didn't. We were detecting cancers, but the cancer detection rate wasn't, you're reading it with TOMO. And I think that TOMO was helpful too. So you always wonder how many additional cancers are we picking up? But I have seen some cancers. I really, really love tomosynthesis and I believe in it. So I'm always really shocked when I see something only on ABUS. I will go back to the TOMO and, look at it and say, where is it? Is it there? I don't know. I think I believe so strongly in TOMO that that it surprises me sometimes when we identify an ABUS only cancer, which we have.
Now, obviously there's a lack of consensus about what supplemental screening we should use. What is screening whole breast ultrasound the main one you all use, or do you use we use TOMO, I think, at the breast center as our means for we use it on everybody because we only have TOMO units there. But what do you think is the best tool for the supplemental screening?
I think the short answer is whichever one you can get your patient to use. I think the reason we have so many different ones in practice all over the country is because there are so many different, practice models. Because in my former practice, we didn't have space for a different unit, and our ultrasounds were at capacity. So there was no way we were going to be able to either do handheld ultrasound or ABUS. We just did not have a place. Like we couldn't even get a closet for something. And so, when we were looking at what we could offer our patients, it came down to contrast enhanced mammography, which was going to be an added expense to get the power injector because we didn't have one at the time, versus an MRI machine that we had capacity on and we already had. So for us, when we were looking at what do we do, it came down to what do we have access to? And I think for some people, for some patients, it comes down to what will my insurance company cover? Because in my current practice, we offer both. We offer ultrasound, handheld ultrasound, and abbreviated breast MRI. And I'm surprised at kind of who gets what. And I think most of it comes down to some insurance companies will cover the ultrasound and they won't cover the MRI. And it's, something is better than nothing.
Mm-hmm.
We're doing MRI, like full on MRI if they're over 20%, and ultrasound if they're not. But occasionally, and I love contrast mammogram, like I think that is a good use for it. And I hope to see more of that, because I just think it really helps you identify, abnormal enhancement and target your ultrasound. And also the background I find is much less than MRI. We've been using contrast mammograms since 2011.
I agree. I agree with you too. And the advantage that contrast mammo has is that it's cheaper and it's more accessible. And so you said that you guys had you had MR in place and you need the power injector, but there's so many places that don't have MR. And so getting that power injector is a lot easier than getting an MR. So I agree with you 100%, Robin. We use the same thing for high risk. We send the patients to a full MR. For, average risk, dense breast, they get an ABUS. And we have contrast mammo, and we haven't been using it for screening. We've been using it for, problem solving and other things, but I would love to increase the number of patients that get contrast mammo. I think it would just really level the playing field for a lot of patients.
The people that use contrast mammogram, do you count as their annual mammogram? Like, can you do it in lieu of? And that's always a question that we kind of run into. Like, I count.
No, I mean, it's low. It's.
I mean, especially now right? Like, now they have contrast tomo, so you're essentially like, it's almost like if you could do those in the intermediate dense population every year, I think it would make our job a lot easier.
Yeah.
So that's the package we have. We have the tomo with contrast mammography.
Mm-hmm.
Actually, we've only been using it for research, and we found, our results are so amazing.
Yeah.
So right now, the surgeons are really excited that we're going to start offering contrast mammography. And so we're going to be offering it to women that can have MRI. But I think Linda, we should really think about expanding contrast mammography to intermediate risk and women with dense breast tissue. Linda and I are so excited about doing contrast mammography. Not everyone feels that way in our group. So it's been sort of a battle, but I think we're gonna we have our first patient scheduled in 2 weeks. So I'm really excited.
We had that as well. I think people are worried. Breast radiologists are worried about contrast, right? Contrast reactions, which really don't happen very often. And mammography techs are not often used to, placing IVs and things like that. So there is some anxiety, but once they get used to it, I think that it really is good for the patient.
Well, that was our issue with the mammography techs until we found one that loved to do it.
Yeah.
So
Some mammo techs have a previous life. We had one that was an interventional radiology tech, and then one that was a CT tech. And so they were very comfortable with contrast. So that helped. So I'm sorry, I didn't mean to digress, but I think that helps too.
I think we need to get a big multi-center trial showing that contrast mammography in that intermediate dense population is really like, there's a lot of utility there.
I love that.
Because right now for the high risk, we're, easily recommending MR, and it's always the, 12, 15, 16% that you're, should I bump it? Should I not? I mean, those are the tough ones that you want to help, and that contrast mammography would be so good for them.
Yeah.
Now, do any of you do handheld ultrasound, or is it?
Yeah, we do a whole breast handheld ultrasound with our techs, and we found I've just started keeping track. Like, just, I feel like in the past year I've had like 6, and they always surprise me. They're all little, and they're subtle. Even the ones that, like, in retrospect, like, you can't even see it. Like, it's pretty shocking.
Mm-hmm. Yeah. Do your techs do it first and then you go in, or?
Yeah, they do the whole thing, and if there's an issue or they see something that bothers them, then we go inside. But they're getting more comfortable. I think we had some pushback at first also from the techs, but they're getting better at it, and we're getting better at it. Like, we're feeling more. First I was going in and scanning every normal, and then I realized that wasn't sustainable. So now I just go in for anyone that they have a question about. But yeah.
And you see a lot of little things that you just,
Yeah,
we were part of the Akron 6666 study, so that was
Well, I
very
think that
enlightening for us.
you
That
find
was-
you find multiple circumscribed masses more.
Yeah,
You
many
almost-
of them. Now I just chew everything. I'm just like, I've seen this so many times that, yeah,
Yeah, right.
good,
We're all getting more comfortable.
yeah. And do you ever do MR just for dense breasts that aren't at high risk?
We don't.
No.
We don't have ABA. We don't have abbreviated MR. That's something I'd want, but like we kind of use contrast there.
And do you offer cash? Do you offer payments? I'm sorry. Do you offer the patients to pay cash for any of these supplemental screening?
We do. Yeah. And so we are mostly doing abbreviated breast MRI as the first line for our supplemental screening. And it is we will run it through insurance to see if they pay, but I would say most of them are denied. And so then it's a cash payment.
How much?
And how much is that?
It is a 500. Well, I've been different places, and usually between $500 and $600 is pretty standard. Yeah.
We don't offer it, but Penn does, and I think it's like $250 or $300. I mean, I guess it's the market.
That's really abbreviated.
Yeah. So we ran the numbers, and that was kind of what you need to like not lose money on your table time.
They lose money
Yeah.
with each one, but it gets people in the system. So I think that's why.
Mhm.
And in our market, a lot, again, we don't have great insurance coverage here because there's no mandate. So not in town, but about 45 minutes outside of town, there's a large group there that was basically recommending whole breast ultrasound on anybody who's dense as a screening, and they were charging $250 a breast. And so that makes the per breast. And so that makes the abbreviated breast MRI very comparable. If insurance isn't covering either one, you're going to get better cancer detection rate with your abbreviated breast MRI. So, but I mean, access is a huge problem.
Yeah. Now, when you do the handheld whole breast ultrasound, so you give them the results right there, right? Or because you're doing it right there. Do you look at the mammo and then the ultrasound together, or?
No, the tech sends them, and then it will show up on the list. I mean, if they have a question, they'll show the person that's in diagnostic, but the person is not getting their results there. I don't know about you.
Oh, okay. So then you'd read the mammo and ultrasound together?
Usually, like often they're scheduled separately, and I don't like on separate days. Like, it's like they have their mammogram, they find out they're dense, and then they come back a separate day. I don't like that as much. I prefer, like
all in one shot.
Yeah.
Then you can read it together, and
you feel more confident.
Don't worry about it. Yeah.
We don't have a huge volume of the screening breast ultrasound, so we actually do read them real time. The techs are the ones doing them, and if they have any questions, then we'll convert it to just a real ultrasound, diagnostic ultrasound, and go in and just take care of it right there. But we can do that because we don't have that many, and we always schedule them during our diagnostic blocks.
Do you have any idea what percentage of your dense breast gets supplemental screening?
That's a great question.
That's a great question.
I don't know. I don't know. What do you think?
If I had to guess, I'd say like 10 to 20%. I think it's like
very low.
Yeah.
Very
I
low.
would say ours is less than 10%.
Mhm.
Yeah, I think so too. So I guess just moving forward, for me, like what's important, or what I think about a lot, is how we can better educate the patients or women who have dense breasts. So I don't know what, other than talking to each one of them, which isn't really realistic in a screening, or maybe have the techs talk to them and tell them they have dense breasts, or I'm not really sure how we can.
I think accounts like Robin's, I mean, she's doing a wonderful job reaching so many people. There's some really great people on social media that are doing a wonderful job, and it's hard work, I think, making all the videos that you make, Robin. But I mean, that's going to help so many patients when they just get that snippet of information, feel comfortable reading it, understand it. I think it's the way that it's presented in some accounts just makes it really non-threatening and accessible, and they enjoy watching it. So
Thank you.
I think it's
Yeah,
great.
I think that's important. Like, I think that there's so much misinformation in breast cancer screening, and just like not even intentionally, just wrong information or just conflicting information, right? Like, so I think that that's really where, as breast radiologists, we can make a difference in people's care, is having a conversation, whether it's on social media or when you have a few minutes with a patient. It's like that patient tells her mom, and that patient tells her, and we just got a great notification about someone whose mammogram missed their breast cancer. It's like, by spreading these stories and sharing these stories, it just might help somebody feel like, oh, but like not be falsely reassured that because they had a normal mammogram, everything's fine.
Mm-hmm.
And just, that's an important message.
I think people connect with stories and real people's stories more than we as breast radiologists love to talk about this stuff, and we could do it all day long, and we do. But we could talk to 10 patients about it, but one person having a personal story can reach hundreds of patients. And I think finding ways to amplify those stories and lift up our patients is really going to be the most effective way for us to get more people, involved and caring and paying attention.
I definitely agree with you. I think as scientists, we always try not to think of like an N of one. And, so we sort of try not to think about that one patient and that one story, but you're completely right that that's the thing that sticks in people's minds. So we have to lean away from that scientific thought of like not making a decision based on one case, but really, we do have to tell those stories. I don't know if that makes sense, but I always think, I always think that it is important to talk about those stories when we're talking to patients.
Well, last year for October Breast Cancer Awareness Month, densebreastinfo.org. I don't know if you're familiar with that. It's just a magnificent website for breast densities for the providers, for the patients. And we did a Spanish-speaking patient that I had from county. And she gave such a beautiful, there was not a dry eye in the house when she was done. It was just such a magnificent video on how she loves to get to take care of herself, and she's grateful for the doctors who see her every year. It was just beautiful. It was just so.
Is it on that website? Is it on that website now? Yeah, that's Nancy Capella. That's the website she started, right?
Hers was, I think, my
breast density. Wait,
yeah,
or densebreast.org.
Are you dense?
Are you dense? Yeah.
Are you dense? Okay. All right.
We're doing I'm going to do a whole podcast on I think it's My Density Matters, or one of those. Yeah. There's a bunch of great organizations about talking all about that.
So good.
Oh, that's great. I think it's really important for us to actually talk to the women in the community. So whenever I get an opportunity to speak to a group of women, I'll take the opportunity to go and talk to them. I think it's also important to make sure that mammogram is still important, because sometimes if you start talking about supplemental ultrasound in women with dense breast tissue, some patients think, well, I have dense breast tissue, so I don't need a mammogram. So I think you have to really
I don't like compression.
You need the mammogram. Unfortunately, they still need the mammogram, and ultrasound is a supplemental study.
Yeah. There also is some compression with the ABUS. I've had it myself, and I think there is some compression. So, but that's a great point that we should talk to patients.
So, is there anything we haven't covered, or are there any other thoughts you want to add, or closing statements? Anything?
I think it would be really important to have a federal mandate. I feel like we have so many different.
I think there is a federal
working on it, right?
It hasn't been implemented yet, but Diane.
Okay, so it went through. It just hasn't been implemented because it was passed, right?
Yeah, 2019, but it hasn't been implemented yet. So hopefully, sooner.
So what is it? I guess I'm unclear at what it's waiting on. If it was,
I'm not sure.
But I think that would make a difference. And I think the hard part is even the breast imagers, radiologists were not all on the same page. Obviously, all of us here are on the same page, just from listening to you, but not everyone feels the way we do. And so I think that some of them feel like they go back and look at the Akron 6666 trial study, which was really it was handheld ultrasound, and it was high risk, right? It wasn't just for dense breasts, it was for high risk women. And so if we're looking at the data that's over 10 years old and really need recent data, and we don't have that, we don't really know. We do know that we find small cancers, additional cancers in with supplemental ultrasound, but does it really help women as far as their, do we extend their lifespan? Is it really helping them? Just like we have the data for mammography, but we don't have it for ultrasound. And so I think that we do need data from automated breast ultrasound. I don't think, so the Akron 666 trial did show that additional cancers were found, 3 to 7 per thousand, but there were all these unnecessary biopsies. But I think the way that we interpret supplemental screening ultrasound, we don't biopsy every little thing. So I don't think that there's a really high biopsy rate, unnecessary biopsy rate, but we don't have scientific data. So it's kind of, it's hard to back it up. Right. But
we've learned a lot about ultrasound now than we did 10 years ago. I mean, I'm much better sonographer than I was then. I wouldn't call back a lot of the stuff that I did then. So
yeah. So Linda and I were the Akron 666 trial, and we were doing ultrasound in high risk women. So we pretty much biopsied every solid mass, and that's why the biopsy rate was so high.
I'm
but
curious.
now we don't interpret ultrasounds that way. So I think the numbers will be a lot different.
Has there been newer data talking about since we've unrolled these, what's happened to these biopsies in BI-RADS3? Has it evened out? Has it plateaued with any new technology? The biopsy rate and callback rate goes up and then it goes down once you get more familiar with it. So
I think there is some data for Connecticut because they started first, right? I don't know that you guys can correct me, but I think that once they started having, some comparison ultrasounds, we have ABUS and we can pull up the old study and compare it if we want to. It is tedious, but we could do that. But also, Akron 666, so we have TOMO now. And if you're reading it together with TOMO, you can put that information together and decide not to call something back because you can see something was stable on the prior year's TOMO. And so you've got a lot more information when you're deciding to call somebody back. So,
so good. So very good. Well, thank you, ladies.
thank you.
Thank you for joining us. Have a great evening. Thanks for everything. Great.
Thank you.
Bye.